Bismillah ar-Rahman ar-Rahim. It's a great pleasure and honor to present this lecture about how do we nurture research practice in medicine. First of all, I want to stress on nurture. What's meant by nurture? Nurture means to develop, to enhance, to grow research in medicine. This is the outline of the presentation. I'll start with a couple of slides on, to introduce to the topics and the types of research and how the research is regulated, and the most important sector of presentation is why we need research in medicine, and I'll end my hopes and direction for the future. I want to emphasize that the objective of research is to establish the statements of William Osler, who said that medicine is a science of uncertainty and an art of probability. So we should get rid of dogmas that medicine is unchanged. Medicine is always changing from day to day and even from hour to hour. This is the hierarchy of education. Start with this is the current and the important to raise reactions and to change knowledge, change behavior, and end with performance changes. So we don't stop at the stage of knowledge. The current education is aiming to change the behavior and change the practice of all the physicians. A medical practice should be based on a sound understanding of the scientific basis of contemporary approaches to diagnosis and the management of diseases. And we should establish in the thinking of the medical students that any person working as medical personnel should be prepared to be capable of thinking critically about how new scientific knowledge applies to clinical medicine. So should be updated, and we should raise in the mind of the medical student that the doctor should read and be updated from the early days of medical school until his death, always reading and updated. So what is the definition of research? It's a systematic investigations including testing and evaluations designed to develop or contribute to generalizable knowledge, or testing a hypothesis against a standard, or a way of solving a problem, or how to answer a question through a study. These are the components of research. Start with the objective and ends with contacts and doing the human subject protection and dissemination of the product of research. There are three types of research. Basic research, and by basic research I mean the research done inside the lab. Translational research, the research done in the lab and it can be translated to human being, and then clinical to affect the human treatment. Research, the basic research or preclinical research, it depends on the basic science which precedes the clinical trials and is almost purely based on theory and animal experiments. And this is one of the places in the Mansoura University, Mansoura Medical Experimental Research Center, that was founded just a couple of years ago, and the objective of this center is to enhance the research capabilities for the postgraduates and for the students. Clinical trial is a comparison test of a medication or other medical treatment versus a placebo, other medications and devices, or the standard medical treatment for a patient's condition. So the basic research is research in the lab, and the clinical trial is the research with the human subject. If I ask a question, what is the most distinguished 20th century greatest medical invention? You can say polio vaccine. It's very important, crucial to combat polio. Penicillin to combat infection. Insulin to treat diabetes. Anti-cancer therapies to treat cancer. Hemodialysis for patients with renal failure, and doing organ transplantation for patients who are suffering from organ failure, or stem cell therapies, which is the treatment nowadays. There is explosion of research in the stem cell. Professor Dennis Galling stated that the most important medical invention in the 20th century is the clinical trial establishment, because this is a fundamental tool of modern medicine. The timeline for drug development: the drug starts in the lab for 3.5 years, doing experiments with the animals and testing the safety and the biological activity in the animals. And this is the for each 5,000 compound evaluated, you can find 5 enter the clinical trials. And the clinical trials for any drug passes through 3 stages. Phase 1, which included 20 to 80 healthy volunteers. And the aim of phase 1 is to determine safety and dosage of the drug. Phase 2 includes a larger number of patients, volunteers, from 100 to 300. And this is, the aim is to evaluate the effectiveness and looking for side effects. And then, if the drug passes phase 1 and phase 2, phase 3 is very important and includes 1,000 to 300 patients, volunteers, and this stage 3 or phase 3 drug study, it's verify the effectiveness and safety of the drug. And as you see, for each 5,000 compounds tested in the preclinical testing, only 5 enter the human studies. So 1 for each 1,000 drug idea. And then FDA, which is the Food and Drug Administration in the United States, take 2.5 years to review and test the drug. And for each 5 drugs enter the human, only 1 approved from FDA. So the drug journey takes almost 12 years. For each 5,000 drug tested in the experiment, only 1 drug finds its way to the human being. And moreover, when the drug is marketed, it is followed up for forever in the phase 4 post-marketing. And if there is any striking side effects, the drug can be withdrawn at any time point. Regarding pregnancy, this is a very important and this is a special situation. And to use drug in pregnancy is of great care, and the FDA established this evaluation strategy as they nominate the drug either category A, B, C, D, or X. What's meant by category A? Category A is almost safe, and there is no hazard to give the drug for the pregnant ladies. Category B is almost safe as well. So if the drug is labeled A or B, we can give the drug to pregnant ladies. But if the drug is labeled C, there is harm and there is benefit. And we can give the drug if the benefit exceeds the harm. Like, for example, when we treat patients with renal failure with immune suppressive therapy after transplantation, if we stopped all the immune suppressive drugs because we are afraid of the hazards of these drugs on pregnancy outcome, then the patients may develop rejection. And the hazard of rejections are more dangerous than the use of immune suppressive drugs. Drug labeled D means that is relatively contraindicated. And if the drug is labeled X, this is absolute contraindicated, like methotrexate in pregnancy. So what kind of the study, the clinical study we use? The most important question is, we should ask ourselves, if the investigator assigned or intended to intervene, if it is no, this is observational study. If the investigator intended to intervene, this is experimental study. So, we ask ourselves, did the investigator assign exposure? If no, this is an observational study. And then we ask ourselves if there is any 2 groups for comparison. If no 2 groups for comparison and it's only 1 group, this is descriptive study. But if there are 2 groups, we ask ourselves, what is the relations between the exposure and the outcome? If we start with the exposure and follow the patients to search for the outcome, this is cohort study. If we start with the outcome and we evaluate the patient in the back, in the past history, to know the exposure, this is case control study. If both the exposure and outcome occur simultaneously, like we take the snapshot for the population, this is cross-sectional study. If there is intention to intervene, this is experimental study, and this is classified into either randomized or non-randomized study. And this will be taken in details when we are going to discuss the study design sector in the proceeding of the course. I want to stress upon that for each study there is a specific question. So each study can answer a specific question. If we want to assess the efficacy of any drug, the best study to be followed is a randomized control trial. If we want to assess the harm of the drug, the best is a cohort or case control study or case series. If you want to evaluate the cost, economic analysis is the best for that. But take care, because there is an ethics dilemma that controls the research environment, and this is known as Belmont Report. Depends on 3 ethical components: doing beneficence, and working justice, and fairness, and respect the autonomy of the patients, including the study. Was meant by beneficence, the research should benefit the subjects or social in general. So the research should be beneficial. If I'm doing research to do harm, this is non-ethical and should be avoided. The risk from the research should be balanced with the expected benefits. Regarding justice, no one segment of the population should bear the burden of research. For example, if we are staying in the United States of America, including the only African American, the black people in the study, this is breaching of the ethics of the research. So no one segment of the population should bear the burden of research. The benefit of research should be evenly distributed among all society. Respecting the patient autonomy, and one of the most important is informed consent. What's meant by informed consent? Informed consent means that we discuss with the person included in the study, discussing everything about the consequences of the treatment and the hazards of treatment. If we just say to him, please share us in this research and sign here, and the patient sign to participate in research, and you don't explain to him the hazards or consequences of his participation, this is not an informed consent. So informed consent is a consent after thorough exploration of all the hazards, and the patient at the end consent to participate. There are many authority bodies to fund the research, like in if you look here in the United States of America in 2003, they suggest that about $94 billion were provided for biomedical research. The National Institute of Health, Pharmaceutical, and the biotechnology companies take care and participate in the funding research. There are many regulations like European Medical Agency and FDA. The most important sector of this presentation, why should we have medical research? Why? Because research may improve and monitor and guide the best medicine for the patient's welfare. For example, if you look here to this data, you can find that management of hypertension in the United States through the different decades. You can find there is difference between awareness, treatment, and control. And if you look here just in a brief, if you look to the decade between 1999 and 2004, you can find the majority of the patients are uncontrolled, and this is known as hypertension paradox. Because although the populations are aware of hypertension, and there are many classes of antihypertensive drugs, blood pressure is still uncontrolled. So how can we know this data? Except from having the data from research. One of the important questions, if I am treating a patient with ischemic heart disease, can we aggressively lower blood pressure for these patients? This study included more than 22,000 patients, including, if you look here to the results, you can find that the best blood pressure in systolic blood pressure between 120 to 130. The higher and the lower the systolic blood pressure, the poorer the outcome. The same for the systolic blood pressure. So there is a cutoff point. Below and above that cutoff point, the side effects occurs. Do you recommend, and a second question, do you recommend intensive blood pressure control in type 2 diabetes mellitus? By intensive blood pressure control, I mean to reduce blood pressure, systolic blood pressure below 120. This was the question of depends upon the data coming from the JNC7, Joint National Committee, the report 7s, that stated the normal blood pressure in adult is below 120/80, and pre-hypertension is considered if systole between 120 to 139, or diastole between 80 to 89. Hypertension stage 1, if systole between 140 to 159, or diastole between 90 to 99. Hypertension stage 2, if exceeding or equal 160/100. The question now, Regarding pre-hypertension stage, is it hypertension or not? The statement is, if the patient is risky, has some risks of cardiovascular like diabetes, we consider him as hypertensive and we treat him. So the question was taken in consideration in this study, the ACCORD study, that evaluated the effects of intensive blood pressure control in type 2 diabetes mellitus, targeting systolic blood pressure below 120 systolic blood pressure. This study included 4,700 cases. The patients were randomly assigned to intensive therapy, targeting systolic blood pressure below 120, this is intensive arm, or the standard therapy, systolic blood pressure below 140. The mean follow-up period for 4.7 years, and if you look here carefully, you'll find they achieve the goal. Either a standard treatment, is the systolic blood pressure below 140, or through the study, or intensive systolic blood pressure below 120. What are the results? You can find hypotension in the intensive treated group, but you can say this is a price that should be extracted to benefit the heart, brain, kidney, etc. But look here, creatinine increased in the intensive treated group. So, and there was no difference in the primary outcome, non-fatal stroke, non-fatal myocardial infarction, death from cardiovascular disease. So these results provide no evidence that the strategy of intensive blood pressure control reduces the rate of composite of major cardiovascular events in such patients. There are several limitations. This is the most important issue. When we read any study, even this study was published in New England Journal of Medicine, we should look and search for the limitation of the study. And we should, the randomized controlled trial, solve the problem of selection bias. But we cannot generalize the results of randomized study. We should look at the demographic characteristics of the patients, and we cannot generalize this result for all population. The second point of limitation here, the trial was open label. What's meant by open label? Open label means that the patient and doctor know that the patient is either in the intensive or the standard treatment group. The second point, the rate of cardiovascular events was lower than the expected rate in the standard therapy group. Thirdly, patients younger than 40 or older than 79 were not included in this study. So when we read the data and when we look at the result, we should put in our consideration this limitation. Another important point, when chronic kidney disease or coronary failures occur due to hypertension, so this is hypertension, hypertensive chronic kidney disease. Is it wise to aggressively treat blood pressure to protect the kidney from progression? This is a question of this study, ASK trial, intensive blood pressure control in hypertensive chronic kidney disease patients. The study included 1,000 black patients with hypertension, that's blood pressure above 95, and CKD was diagnosed by the gold standard isotopic clearance, and the patients, the clearance was between 20 to 65, and the patients were randomly assigned to intensive therapy or standard therapy, and you can see the result of the study. There was no difference between the patients who are in the intensive arm or the standard arm. Only there is, when they further assess the results, put in consideration the basal proteinuria level, they found that some advantage of intensive treatment for the patients with proteinuria exceeding 220 milligrams per day. Statin therapy is a class of treatment that is well known to treat hypercholesterolemia. But there is some assumption that statins may have many pleiotropic effects, like antihypertensive effect. The PHYLLIS study is a statin antihypertensive treatment and blood pressure control in clinics and over 24 hours. They showed the study was conducted in a randomized double-blind trial. Double-blind means that the physician and the patients, both of them, don't know either the patient received the active statin or the placebo, and only the principal investigator knows that. So this study included 508 patients, and this is the age of the patient between 45 and 70 years. The randomized placebo-controlled double-blind trial, and the participants were randomized to receive antihypertensive treatment with or without the addition of statin. Pravastatin 40 milligram once daily, and the clinical and ambulatory blood pressure measured every year throughout and average 2.6 years. So there are many strengths in the study. Number one, double blind. Number two, depending the measure of blood pressure on ambulatory and office blood pressure, and the results was negative. There is no antihypertensive for statin. One of the important concepts in nephrology practice is dialysis. Until last year, the dogma was if we treat the patient with dialysis earlier, this will improve the environment, the uremic environment, and instead of starting dialysis late. And this is what we learned through our practice. But last year, look at this data. This is one of the studies, ideal study, the randomized control trial of early versus late initiation of dialysis. They categorize the patients at the time of initiation of dialysis into two groups. Both groups are within stage 5, that means below 15 ml per minute, estimate GFR, and they divide the patients into early versus late dialysis. Early dialysis, dialysing the patients with GFR between 10 to 14, versus late dialysis between 5 and 7. By our expectation from the previous experience, we are expecting that the earlier the dialysis, the better the outcome. But look here, the data showed no difference between the patients who are dialyzed early or dialyzed late. And the conclusion was, in this study, planned early initiation of dialysis in patients with stage 5 chronic kidney disease was not associated with an improvement in survival or clinical outcome. Look at this data. This observational study came from United States Renal Data System. Look at the figure is very impressive. Approximate 1 million patients. 896,000 patients included in this observational study. Why this big figure? Because they have a well-developed statistics. They can collect the data accurately, and this is an invitation here in Egypt and developing countries to have our data in our hands. They categorize the patients according to the estimated GFR at the time of initiation of dialysis to 4 groups, either above 15 or between 10 to 15, between 5 to 10 or below 5. What happened? They found that the best survival attained to the patient in the arm from 0 to 5. This means that the earlier the dialysis, the worse the outcome, because mortality are higher if we start earlier, and survival is better if we start late. So, the current medicine, we don't start dialysis early, in stage 5, except if the patient is symptomatic. So we should respect patient symptomatology, and we don't dialyze the numerical data of creatinine or lab. So we take our decision based upon clinical data and the laboratory data. One of the important concepts in nephrology is treating acute renal failure with renal dose dopamine. The nephrologists are accustomed to use renal dose dopamine for the patients with acute kidney injury. But research proved that the use of this renal dose is not useful and should be abandoned. So the recurrent recommendation is avoid this term. It's out of the medicine now. Another important point, as nephrologists, we were afraid of noradrenaline because noradrenaline infusion in treatment of septic shock can lead to vasoconstriction. So the nephrologists are aware of the vasoconstrictor effect of noradrenaline on the kidney. But the study and the research proved that this is the only drug is beneficial because it improves blood perfusion to kidney by many mechanisms, and the vasoconstriction is just a trivial mechanism. So it improves renal function and it should be given to treat septic shock. Regarding obesity, obesity in general population is associated with high mortality. But the question is, do you expect the same association with mortality in hemodialysis? If you look at the data coming from this study, you can find that the higher the body mass index, even above 40, and this is the morbid obesity, the better the survival respective to the race of the patient, and you can find the superiority for even the plaque. Why obesity in dialysis is beneficial? Because it denotes the good nutrition of the patient in dialysis, and the main killer of the patient in dialysis is malnutrition. The second point is the higher serum uric acid in general population, the higher the risk for cardiovascular disease and mortality. But in dialysis, it's the same. There is a paradox. The higher the uric acid, the better the survival. And the lower the uric acid, the higher the mortality. And if we know from the literature that the black people in the America are more susceptible to diseases, and the mortality generally are higher. Mortality rates are higher in black patients than the Caucasian patients in the United States of America. But in dialysis, you can find a paradox. Black patients live longer on dialysis in comparison to Caucasian patients, and this is maybe explained with the lower tendency of inflammation in black patients in the United States. What is the best blood pressure target in hemodialysis? If we say this in the general population, should be within normal. It is 130 to 80. It's below 140, 90 to 130, 80. But here in dialysis, the systolic blood pressure, if it is below 140, the hazard ratio of mortality increases respective to the systolic blood pressure. And the striking effect of the lower systolic blood pressure is more evident in aged patients, and the beneficial effects, the range of systolic blood pressure is very wide, from 140 to 180 in this population. The lower the diastolic blood pressure, below 80, the higher the mortality in dialysis patients. In general population, wide pulse pressure is an independent risk factor for cardiovascular disease and mortality, but in dialysis patients, the lower pulse pressure, the higher the mortality, and this is dialysis paradox. So, in the previous example showed that the research is very important to change our mind, to give some valuable data, and even to correct the treatment or change the treatment of the patients. One of the important issues of research, it can conduct this break news. For example, this December, the European Medicine Agency announced that aliskiren is stopped as a management on top of ACE inhibitors or angiotensin receptor blocker, to the extent that Professor Abdelmajid Nahas mentioned in the online academy that altitude stopped, a nail in the coffin of RAS inhibition, or is it a misunderstanding of the nature of modern day diabetic kidney disease? We should understand that there is a great disparity and difference between type 1 and type 2 diabetes mellitus. Type 1, if the patient is type 1 and the proteinuric ACE inhibitors and RAS inhibition is superior, but if the patient is old age and type 2 diabetes and with a lot of atherosclerosis, the use of RAS inhibitor may be cautious given to these patients. And even in dialysis, the use of growth hormone to treat malnutrition the study is prematurely stopped, and there is no superiority to give growth hormone to these patients. One of the important issues from research is to achieve breakthrough. So if you look here, this is from the Telegraph. The banks of the shelf body parts could be created for transplant, researchers said. This is from research. And another point, scientists here in the Edinburgh, in the last April, they celebrated the creation of human kidney, half centimeter, and this is breakthrough from amniotic fluid, of human amniotic fluid and rat mice, the rat stem cell, and they created human kidney, half centimeter, and they are dreaming this kidney will grow in the future. In the kidney, in the treatment of the patient with dialysis, there is a bioartificial kidney by doing dialysis by the conventional filter, and then the blood is allowed to pass through another filter, including proximal tubular cells, and this is a breakthrough. And one of the obstacles is that if we take proximal tubular cells from immortalized cell line, the cells can grow and obstruct the capillary of the dialyzer, but by creation specific methods of enhancing the growth of the cells to some extent, and then stop the bioregulation cell cycle, this allow the bioartificial kidney to work and avoid the blocking of the filters. If the patient with congestive heart failure, they can take the opportunity to go all through the hospital with this apparatus, and you can see here the apparatus is connected to the blood through the fine catheters, and then the patient can adjust the ultrafiltration just by remote control while he is walking through the hospital. And even the magnetic separation by injecting nanomagnets specific for drug or toxins. You can see here this curve, the nanomagnet is specific for digoxin, and with application of magnetic separation to the extracorporeal blood, we can get rid of digoxin. Even after half an hour, you can find the the blood level within the therapeutic window. Another area is the establishment of smart drugs and use of nanotechnology to deliver the drugs to the body and to treat cancer by using magnets. This is one of the important issues. We can use stem cell even to deliver drugs like glucagonide peptide 1 in treatment of the spinal traumatic brain injury. If you look here, this is the stem cell encapsulated and transfected with the gene to produce GLIB1, glucagonide peptide 1 receptor are present in the brain. And if we inject these cells to the injured sites, they release glucagon peptide like 1 that stimulate the regeneration inside the brain. Another important point and the value of research in medicine is establishment of evidence-based medicine. And we are in real need, because evidence-based medicine is the integration of the best research evidence with clinical expertise and patient's value. But take care, because not all maneuvers or treatments can be based on the evidence-based medicine. For example, if individuals who insist that all interventions need to be validated by a randomized control trial need to come down to earth with a bomb when they want to evaluate the use of parachute in a randomized study to combat the gravitational injury. And these are the components of evidence-based practice. We start with asking an answerable question, then access the data, the evidence, then appraising the evidence, apply the appropriate evidence, and end with assessment of the process. There are 2 points. When we are dealing with evidence-based medicine and recommendations, there are 2 points. There is a level of recommendation, and there is a level of evidence. What's meant by level of recommendation? There are 2 levels of recommendation. The first level is strong level, which means we recommend, and this can be taken as policy in decision making, and the relatively weaker stage, which we suggest and it can be debated. But the evidence came from studies, and this is either strong A level, B moderate, C low, or D very low according to the study design. I want to emphasize that the majority of situation, the level of recommendation goes hand with the level of evidence. But if I ask you a question regarding the use of dialysis to treat symptomatic end-stage kidney disease, what is the level of evidence here? The level of recommendation is level 1, we recommend, but the level of evidence is B, because there is no randomized, double-blind randomized study to evaluate the use of dialysis in this situation, because if we deprive the patient from dialysis, it's an ethical problem. So in this month, Professor Ahmed has visited Mansoura, and there in his magnificent presentation in Mansoura Nephrology master class at the Qalia Medical Syndicate, here is the issue of when we treat the patient, we should ask ourselves 5 W questions. First question is why we are applying this intervention. When I want to write any medications, I should ask myself why I want to write this medication to these patients. What is the evidence? Is it from my senior professor? This is dogma should be we should get rid of this dogma. We shouldn't imitate our professors. We should read and search for the evidence for our intervention. Who is benefiting from this intervention? What is the risk-benefit ratio? And what is the cost-benefit for this intervention? So don't forget to ask yourself when you are dealing with any patients the 5 W important questions. And by these 5 W questions that I agree with Professor Nahas that the critical appraisal in making clinical decision is of paramount importance and should be applied by all doctors. Other benefits of doing research is to be recognized. Professor Ghanim is recognized all over the world by his research. Also Professor Sabh and Professor Shukir, who is awarded from the national, international, and even intercontinental prizes. Professor Hussin A for his creations in the management of cancer bladder. And the most important, the center is well known by the research coming from the center, to the extent that the European Renal Associations respect the center, and they collaborated with us in the hemodialysis course that was held in October, and they will participate in the next course, the 5th International Hemodialysis course, in the next September. Another important point that, depending on research, the universities were ranked and stratified, and you can see the top 10 universities over the world in this year. You'll find the majority from the United States of America, and the decision is based primarily on research. If you look at Africa, you can find the 3 universities from Egypt, the Cairo University in the 8th level, and Mansoura in the 15th rank. And if you look to the rank over the world, you'll find the Cairo University is 1,200 and Mansoura is 1,700. So this is our rank. Nobel Prize is awarded according to research, and if you see here, this is the Nobel Prize in Physiology or Medicine this year, between the 3 professors. 2 of them discovered the innate immunity, and the other discovered the role of dendritic cells. And this in 2010 for in vitro fertilization. And this is the discovery of chromosomes, discovery of viruses, discovery. So you can see with me that the prize is given for striking and the innovations and deserve. There is no bias in these prizes. All of them deserve the prize. If you look here, this is in 1990, Professor Joseph Murray. I have the pleasure and honor to have the photo with him 3 years ago at Harvard Medical School. Professor Joseph Murray was the first surgeon who did the world's first successful renal transplant at Brigham and Women's Hospital in December 1954. And even in the first award for the medicine and or physiology in 1901 for the Professor Behring about his discovery of serum therapy in treatment of diphtheria, and in 1902 in treatment of malaria. And this is the youngest person who was awarded Nobel Prize while he was aged 32 years in 1923 about discovery of insulin treating diabetes. The main problem that I don't like this table, because among these people who are awarded, there are a lot of Jewish, 53 Jewish and non-Egyptian in this, although our culture is very old and this is the oldest culture in the world. And when the Champollion discovered the alphabetics of this language by comparing the script on the Rosetta Stone, he knows that this means we want to drink or to sleep. And by this way, he discovered in this papyrus paper that the ancient Egyptians know well how to treat rheumas, how to diagnose cancer colon, and when the cancer is advanced, no treatment is recommended. And even they created the images of prosthesis, as you see. And here I nominate 2 persons, Hisra and Besichet. Besichet, this is an old female physician in Egypt in 2004 BC, and she is the lady overseer of female physicians. And then the ancient Egyptian people know well the instruments and those circumcision. And when Obama visited Egypt, the media was busy. Why Obama selected Egypt in the Middle East to be visited? The simple answer is because Egypt is Egypt, 7,000 years of history. And Ahmed Zewail is well known because he is a Nobel laureate in the science about his discovery in the femtochemistry. And its application in medicine is striking, because when I made this research yesterday, I found more than 150 publication in medicine published by Ahmed Zewail, and I am expecting that he will honor the Nobel Prize in Medicine in the future, near future. What's urgently needed to make evolution in medicine is to raise the talents, to select the talents, and doing a training for these people, giving some time to them, and selecting the best teacher for them, and the development of teamwork, because research depends on the team, and every person on the team is very important and crucial, as well as the principal investigator. And I just take the statement from Professor Zewail when he was selected and awarded the best leaders in America this year, when he said that leadership is offspring of vision. I agree with him totally. And our role in the Mansoura Manchester research curriculum is to inspire the medical students to dream of a better future, and the change of the practice of medicine start with this young generation. I am a big believer of the young people, and this generation, they are working hardly, seriously, and I am so happy by that. And you can find they are working the team in the Medical Research Center with the group of Professor Swabha. This is Dr. Saeed Abdelhadi, the director of the Mansoura Manchester program. And this is one of the important issues that we collect the medical students, 10 from Manchester and 10 from the regular Mansoura Medical School, and they did a lot of research in the summer as elective without any marks. They are devoted and enthusiastic to doing this research, and the research process were targeting acute kidney injury and its correlation and relation with other system, body system, and because the acute kidney injury doesn't mean acute renal failure only, but it affects the other organs like liver, brain, pancreas, etc. And you can see here in this, the students put a clamp on the artery of the kidney. You can find the kidney here is black in comparison to the other kidney. And if we put our hand together, and I think this will change the medicine in Egypt, and we should put in our mind not just to be on the PubMed, but to publish in the most prestigious journals like New England Science, Nature's, etc. And I want to end the presentation with this قول الشاعر: العلم مبلغ قوم ذروة الشرف، وصاحب العلم محفوظ من التلف. يا صاحب العلم مهلا لا تدنسه، بالموبقات فما للعلم من خلف. العلم يرفع بيتا لا عماد له، والجهل يهدم بيت العز والشرف. ولابد نستعيد الأمجاد بتاعتنا، الحضارة بتاعتنا عريقة، ويستحق إن احنا نعمل الكثير لاستعادة الماضي الخالد. وشكرا جزيلا.